Hello friends, let us study about the cerebellar lesion.
What are the features of cerebellar lesion? This is usually asked in the prof exams, that mention the features of cerebellar lesion. If I know the functions, I will know that if those functions are, distorted, disturbed, or absent, what is going to happen. So cerebellar lesion usually manifests as disturbance in tone and posture. That features could be like atonia or hypotonia, where tone is reduced. There might be an attitude change. Attitude change means your posture. It may not be, it will be, there will be an alteration in the posture of the body. That might be a deviation movements. This could affect our deep tendon reflexes also. If there is hypotonia, the reflexes are also going to be reduced. Reflex response is also going to be reduced. With its connection with the vestibular system, it is involved in equilibrium. Okay. And we all know that for maintaining a balance and equilibrium, we require three inputs. One from the vestibular system, other from the visual system, then and the third one is from your cerebellar lesion. It could cause the disturbance in the movements. There is something called as ataxia, and we can tell it by Romberg sign. You remember the Romberg sign or Romberg's test?
Yes, ma'am.
Okay. So when we ask a person to stand with closed eyes, the person may not be able to stand in one way. He may be swaying this way or that way. That type of what we call as ataxia. That was a sensory ataxia. You may also see in cerebellar ataxia. Okay. Then gait will be, it may be like, there is a disturbance with the gait also. Then there is intention tremor. Intention tremor means what? Intention tremor means intention tremor means suppose you are going to pick up an object. You want to pick up a cup or you want to pick up a pen. When you start taking, making a movement, when you start doing you start executing the movement, there will be tremors. Such tremors, we call it as intention tremor. Okay. So here what is happening? When a person who has lost the cerebellar performance, he has lost the cerebellum, or there is some lesion to the cerebellum, what will happen? The movements, they tend to oscillate, and there might be shooting, instead of reaching to this point. Suppose, let me take a pen. There is a cup here, and here is your hand, and you want to reach to hold this cup. Had there been no cerebellum, what would happen? You would have overshooted. You would have just gone to different directions. Or the other thing is, when you are going here, there might be oscillations. There would have been some tremor. This tremors is what you call as intention tremor. Then we know that cerebellum has got connections with the superior colliculus, has got connections with the vestibular nuclei, which has connections with the third, fourth, sixth cranial nerve, which are involved in eye movements. Hence, we know that there could be nystagmus. We have learned about nystagmus there. If there is a cerebellar lesion, we may see that there would be cerebellar nystagmus. Okay. So you may find that the person is, his eyes, is making a lot of saccades, or you can say lot of tremendous movements of the eyes when rather than making a steady fixation. So if you ask him, this is the fixation point, fix your vision here. Instead of having a constant fixation, there will be eye movements this side or that side. So that is what you call as the nystagmus. Dysarthria. Dysarthria is what? When there is lesion in the cerebellum, there may be a problem in speech. As we know, movements of such as dancing, writing, rapid movements. We know that rapid movements, they require cerebellum. Speech is a coordinated movements of many things. Okay. Phonation is included, movement of the tongue is included, folding of the tongue is included. Then your respiratory, there is some regulation to that also. So dysarthria, since it is actually a coordinated movement, if there is a cerebellar lesion, we'll find that the person's speech is slurred speech. This is dysarthria, difficulty in speech. Fine. Then there may be dystocia also. So let us go now as what are the tests that we do for cerebellar dysfunction. What tests do we do in the lab? Have you done any tests in the practical lab?
Ma'am, finger nose test we
You
have
have done
done.
the finger nose test? Can you tell me how do we do the finger nose test?
Ma'am, once we keep distant our finger, then with open eyes we touch our nose tip, and then we do it again with closed eyes.
Okay. So if there was no cerebellum, you wouldn't have reached your fingers, or you could have touched instead of finger, you might instead of the nose, you would have touched any other part of your face. Now, what is this adiadokinesia? This I can tell you. Suppose you are doing any rapid movement. Have you done the adiadokinesia? So one palm, you are going to make it in a supination position. The other, you're going to put the other palm on that. And what you do, you just put the other hand up and down. Just turn it. Do the rapid movement. So cerebellum, since is involved in rapid movement, a person with cerebellar dysfunction will be unable to do this rapid movement of the hand. Then there could be rebound phenomena. How did you do the rebound phenomena? Rebound test is like, suppose you, let me just draw this. Suppose this is the arm. Okay. Here is the hand. What will be the other person who is standing here going to do? He is going to put his palm here and he's going to give resistance lower. He's going to pull it down. And what will this person do? He'll try to flex his arm. This person is trying to pull it down and the subject is trying to flex his arm. Suddenly, if I leave his hand, this person, if suddenly leaves his hand, what will happen? This hand is going to rebound like this, right? Go back. There will be, suddenly there will be a movement. And if this is his face, it may strike his face. Had there been no control of the cerebellum, they would have got rebounded and he would have slapped himself. He's not able to do, or normally, there is a resistance. So when he's trying to flex, he just stops in the midway. Instead of slapping himself, he stops in the midway. And this is what is called as rebound phenomena. So it is a reflex. It's actually a cerebellar examination. When we do the cerebellar examination, we usually try to perform the finger nose test. Then we ask the person to do this adiadokinesia, means do the rapid hand movements, supination, pronation. Then you ask the person to do the rebound phenomena. For rebound phenomena, you need to take a examinee and an examiner, both of them. You're going to ask them to do that. Okay. Then is the gait test. How is the gait test done? So how do we do the gait test? Ask a person to walk down or walk like this, and you observe his gait, and you ask from one end to the another end, you ask a person to walk and then turn back. So he is completing one cycle. As you're asking this person, you observe the gait. Ataxic gait is the one which is ataxic, broad base, means he'll have his legs apart, far more apart when he's trying to walk. So this probably is due to the lesion of the cerebellar, which could be due to multiple sclerosis or could be due to degeneration of the cerebellar vermis. If you remember, vermis was the one which was connected with the spinocerebellar pathway, and so it is the one which is involved. So if I have a damage at the vermal area or the paravermal area due to any, usually the lesion could be due to vascular lesion or it could be like multiple sclerosis, where we find there is an autoimmune disorder, there is demyelination of the fibers, and so that could be there. We find a broad-based ataxic gait. Okay, the person goes with both of his limbs apart. People who have issues with the cerebellum, the turning could be one reason. There could be, this turning. When we ask a person to turn back, people with cerebellar lesion might be having a problem in doing the turning maneuver. There is something called as heel to toe. There is one more test. What do you ask? You ask the person for ask the patient to walk to the end of the examination room and back with their heel to toes. Okay, you just ask them to walk with the heel, put the leg down, up will be the toes, and ask them to walk. People with cerebellar problem it will be very difficult for them. They may fall down. Okay, there will be a tandem gait if there is any cerebellar lesion. Then past pointing. Romberg sign, you have seen it? Romberg sign, do you remember? So in that, how do you do? You ask a person, you position yourself near to the patient, ask the patient to put the 2 feet close to each other, stand an erect posture, and then ask him to close the eyes. On closing of the eyes, if it is Romberg's positive, we find that he tries to fall,
Swaying.
without correcting. And if you're not there to hold him, he may just fall down. Okay. So that's what is the Romberg sign. Then comes the speech. Even you can ask the person for a speech test can be done. Ask him to read a sentence. Okay. Give him some words or give him some sentences. Look at how he is pronouncing it. Is there any slurred speech? Is the speech very clear? That is also one more test. Then you can look for eye or the nystagmus. Okay, you can go for nystagmus test. How will I do the nystagmus test? What you do, you ask a patient to, bring something close to him or ask him to make, show your finger to this side and that side. You ask him to look ahead, examine how, make him to fix his vision to one point. Suppose this is my fixation point and I'll ask the patient or this, our subject to look at this fixation point. When he's trying to fix to this, fix his gaze to this, we'll look for the eye movement. If there is to and fro movement, that shows there is nystagmus, which probably is an abnormal movement of the eye. Then you can ask him to keep his head fixed and you move your finger test. You move your finger from this direction to this direction. So you will see again, you'll try to observe what is his eye movement. Is there any abnormality to that? Or you can make an H with your finger. Make a H in the air and you try to see what happens to his eye movement. So these are some way that you can know as what exactly is the issues. Okay. Next we can do is this past pointing. Past pointing is what? Past pointing is probably, you try to bring both the fingers together with your eyes closed. You close your eyes, bring both of the index finger together very quickly. When you do that, if you all are normal, there will be that we'll try to immediately, bring it together, point at one point. If there is some cerebellar lesion, he may point this way, then he'll try to correct, or if there is no correction, he will past point it. Means the pointing is not correctly to each other. Then you may also go for, you may check for reflexes. In cerebellar lesions, you can check for reflexes. And the most important ones we know is which one? Knee jerk. What do you think will happen to this patient with cerebellar lesion? What did we learn? There is alteration of the tone, right? In cerebellar diseases, this reflexes described as pendular, which means less brisk and slower in rise and fall. What does this mean? What is knee reflex? First of all, we'll try to understand. So knee reflex, do you remember?
Yes, ma'am.
Yes. So you tap the tendon, provided your patient is not an, obese, heavily obese person. Too obese, you don't know where you have hit him, whether you have hit him in the tendon or you have just hit the fat. Thinking that you have hit him directly to the tendon, what is our expected movement? There will be extension of the limb, isn't it? It has to be very fast. There is a fast extension of the limb. If there is a cerebellar lesion, what will be there? Instead of this quick extension, will find a pendular type of movement. What does mean? Slowly it is going to go up and slowly it is going to come back. Got my point? And this is happening due to there is reduced tone. You remember, tone is a function of cerebellum. And if there is a lesion
Yes,
in the
ma'am.
cerebellum itself, there will be hypotonia. And in hypotonia, what happens to the reflexes? They become hyporeflexia, right? Do you remember?
Yes, ma'am.
Yes. Other than these 5-1 which I have described, there are still more others. You can do it in a patient whom you suspect that there is a cerebellar lesion and you want to know as what exactly it is. So a lot of assessments can be there. There are huge list of tests which we can do while checking the cerebellar examination, while doing the cerebellar examination. Okay. So remember that there is a mnemonic to understand the phenomena. Do you remember that? This is called as the niche. D-A-N-I-S-H. You are going to tell me. D stands for dysdiadokinesia. The problem in this rapid alternate movements you're not able to do. Dysdiadokinesia. Then comes ataxia. A stands for ataxia. Okay. Gait and posture you'll see there is. N will stand for nystagmus. I is going to stand for intention tremor. Yes. And S is going to stand for, what will you write? Slurred speech.
Slurred speech.
And H may stands for hypotonia. So if I ask you, what are the, if you want to remember it, that for cerebellar examinations, what are the main features you have to see and then conclude that there is cerebellar dysfunction. You might have to do all these tests, and from these tests or other few more, just remember this. The niche. D-A-N-I-S-H. D, dysdiadokinesia. Issue in doing the rapid movements, to pronation, supination movement, rapid movements, there is lost. A stands for ataxia.
Ataxia.
N stands for nystagmus.
Nystagmus.
I stands for intention tremor. When you're trying to
Tremor.
hold something, there is intention tremor. Then ask him to read something. You know that there is slurred speech.
Slurred speech.
And you try to elicit the knee jerk reflex, and you will find that instead of having
Hypotonia.
a normal reflex, what do I find? There is decrease in the reflex activity
Tone.
because of decreased hypotone, and that's what we call as H is for hypotonia. Clear? So
Yes, ma'am.
here we end our lesson of cerebellum.